Okay, thank you so much. We have to wrap up. We'll have more discussion in the small group sessions. Thank you, Irene. It's my great pleasure to introduce our next speaker, Jean Ouellet, who comes from Montreal, pediatric and adult orthopedic surgeon and professor of pediatric surgery at McGill University. He's at both the Shriners and Montreal Children's Hospital and a fantastic orthopedic surgeon, so we're really privileged to have him here today. Thank you, Jean.
Thank you very much, and I want to thank the organizing committee to allow me to come and speak to you. And I think I would like to start off that Kevin sort of brought up, Kevin from Calgary, I don't know if he's, sort of asked, why are patients needing to fight for care? And he had sort of summed it up to, is it because of risk or is it because of cost? And I would really tell you that it's neither, it's really ignorance. And that, unfortunately, as physicians, as we go through our training, we're supposed to be the source of knowledge. And the reality is that we're very uncomfortable when either patients or colleagues are sort of challenging us in respect to, well, maybe we don't know everything. And we're really taught that, if you're driving in a field and you see an animal that has 4 legs and it's white and black, well, it's most likely a cow and there's nothing else. Well, I would tell you that you are the zebras. And that even though you live in Canada, the reality is that as physicians, we do not appreciate that. And if we don't, this is where we really get into trouble. And as an academic surgeon, one of the things that I always try to teach, the blunt, dumb orthopods, is to take time to listen to your patients. Because, sitting down and listening to the mothers and listening to the patients, you actually really start appreciating subtleties, and that Loeys-Dietz and Marfan's and all the other diseases that are going to come out through genetic testing and so on, we will learn so much. And that I think these venues and these patient advocacy groups are crucial, and I think I'm really here so that I learn more and we do share experience and we're able to sort of come to a better treatment. So that being said, from an orthopedic point of view, I'm going to just try to give you a bit of an overbrief of at least of what I understand of connective tissue disorders and how it affects orthopedics. So really it's to try to identify or highlight some of the orthopedic pathologies that are associated with connective tissue disorders and really heritable aortic disorders. Highlight some of the importance, and I would tell you again, just like all the other type of treatments, it's really this early detection and really early intervention that I think if you walk away from this conference, this is a key message that you need to, the more you inform yourself about what you do have or some of the condition, what you're at risk of, and knowing those signs and symptoms, or at least the early ones, be an advocate and go and get that treatment. The other one is really just basic principles, sort of orthopedic management regarding connective tissue disorders. So orthopedic deformities really come in all shapes and forms, and the reality is that the underlying diagnosis for all these deformities are not the same. And that if they're not the same, then obviously the management will vary. And that patients that have connective tissue disorders, their scoliosis should not be treated the same way as a child that does not have connective tissue disorders. The way that you look at their feet or their backs is really, your treating physicians really have to appreciate that you should not be treated like everybody else. And if you look again, the difference between Loeys-Dietz and Marfan's, if you look at the recommendations as to hypertension, aneurysm size, and so on, again, it's the subtleties and the details. And that underlying diagnosis does make a huge difference in respect to how you should be treating them. And even more relevant to musculoskeletal problems is that it's really, orthopedics is the management of mechanics and cellular and biological reaction to forces. And that the bulk of our joints and the bulk of our bones are really a combination of connective tissue. And that connective tissue, if there's an abnormality in the building blocks, well, therefore, it's not surprisingly that you end up having some abnormalities. So the particular sort of challenge in connective tissue disorder is that you have this extreme. You could have, even within the same patient, you could have a joint that is limited, i.e. contracted, but can also have another joint that's hypermobile. And therefore, the management of one joint versus the other joint in the same patient is completely different. And that sort of throws off the typical orthopedic surgeon that's sort of looking at, now wait a minute, how come you have a stiff hand, yet your knees and your patellas are all over the place? And that trying to sort of regroup this and trying to establish a diagnosis is a challenge. And therefore, understanding that if the connective tissue is abnormal, then therefore any sort of load, either on the back or on the neck or on the hips, alters those joints and puts them at risk. And that the way that I sort of look at the issue of musculoskeletal disease, and particularly connective tissue disorder, is really this idea that if there is increased laxity, if there's increased subluxation and so on, then therefore the joint and the forces across those joints are at much higher risk. And therefore those joints will be wearing out, may generate pain, as well as deformity. In a child that is growing, again, if the forces are abnormal, then you get angular growth that is deformed, and therefore you see these different abnormalities. So again, just using Brighton's score and looking at the overall laxity, if I have a patient that has some laxity, I'm not as concerned as somebody that has extreme laxity. And that the patient that has increased laxity is at much higher risk of having much more end-stage disease. And therefore, you're looking at early arthritic changes in joints versus rapidity of which the spine may change over time, and specifically looking at scoliosis. So that, if anything, it's sort of, again, breaking things down relatively simple, is that the overall outcome, any type of treatment in respect to orthopedic management, so either bracing, surgery, physical therapy, and so on, in the face of hyperlaxity, then your ability to control and try to prevent disease progression is much more difficult. And that anything that could sort of help to either constrain or provide some additional stability to either the joints or the back and so on, one should initiate that earlier than later, because as time goes by, those joints are being destroyed and you're getting into this vicious cycle where the angular deformity exaggerates the deformity because of the laxity actually accelerates, and you get these vicious cycles that sort of kicks in. So if you look at the orthopedic disorders sort of from a head to toe, sort of what is connective tissue disorders, what can they lead to? Well, there's sort of at the base of the neck, there's obviously your head allows you to look up, down, left, and right, and therefore there's a lot of laxity between that first joint. So if you have a connective tissue disorder, then therefore those joints may be at risk of becoming unstable. So unfortunately, patients that have connective tissue disorders have a high incidence of C1, C2 instability. In respect to the pectus, some of the issues, you're sort of trying to figure out why do these children develop this. If anything, you think about the heart that's pulsating, the lungs that are breathing, you'd expect that things would expand as the soft tissues are not appropriate. I would tell you it's probably the flip side. Again, so when you think about some of the deformities that these patients have, they have constrictures. So there seems to be something that is preventing normal growth, and therefore you get this, instead of having a chest plate that seems to grow in the appropriate fashion, seems to retrovert, and that therefore it is a very obvious clinical signs that you pick up, and that is not one that is easily manageable. And a lot of people sort of say, well, it's much more of an aesthetic issue, and therefore it may be one of the triggers. So that again, when we see a child that comes in an orthopedic clinic that has a pectus, especially carinatum and excavatum, you sort of say, well, this is a red flag. And to a certain degree, this is what, again, being able to dissipate knowledge in our specialties, being able to try to identify those clinical findings that are not standard or not usual. And therefore, there should be bells that are starting to ring in physicians' minds as to, is there some possibility of having a connective tissue disorder? So obviously the sort of pathognomonic or spinal deformities, the scoliosis, and I'll sort of spend a bit more time on that as that's a bit of my area of expertise. But there's also spinal instability, i.e. low back pain. And if you think about a lot of patients that have connective tissue disorders do live with this chronicity of pain, and one of the local sites is really back pain. And that again, the idea behind that is that you have aberrant motion across joints, and therefore those joints are being taxed over time that may trigger pain. There's hand abnormalities, again, this sort of arachnodactyly, camptodactyly, and again, just sort of as an orthopedic surgeon, seeing those in a patient that is in combination of a pectus and a scoliosis, well, again, you're starting to get a few flags that, again, there may be a underlying connective tissue disorder that one needs to sort of address. The issues in respect to hips, as neonates, you have these hip dislocations. So again, it's a hyperlaxity, and therefore the hip joint is really a ball and socket, and that the ball has to sit deeply in the socket and sort of stays there in order for it to develop the socket. Because of laxity, because the ball starts to migrate or move around that joint, so therefore the cup never really develops properly. So it's a bit of an egg and a chicken, so that eventually what happens is that you get these congenital subluxation of the hips. And again, it's a fairly straightforward type of treatment. One is able to just put a brace on that child that makes sure that that hip is sitting deeply into the socket, and therefore you're able to develop and have a stable joint. At the other extreme, as the patients are sort of getting older and so on, then that joint, again, there is an inherent instability, and therefore there's a sloppiness to that joint, and now you're eccentrically loading the joints, and you get early arthritic changes, and you end up with osteoarthritis of the hips. Typically the knees, you have these hypermobile patella that are not tracking in the right direction, because again, some of the ligaments and tissues that normally keep your patella in line are now gradually stretched, and as they continue to stretch, they continue to shift. As they shift, they no longer, you get one side that's tight, the other side is extremely lax, and you get these recurrent or chronic dislocated patellas, which again brings on pain. With respect to the feet, again, you see the spectrum where you may have a rigid club foot, and that yet in the face of a sort of hypotonic child. So how come there's a club foot while there's other joints that are hyperlax? And you get to sort of the other extreme where you have skewed foot, where there's really no inherent ligament structure that keeps the foot and the arch of the foot in appropriate alignment. And as that child grows, the foot just continues to deform, ends up with these severe flat feet that are painful. So just sort of briefly giving you a bit of an overview as to, we're talking about cervical instability, scoliosis, and a bit of a club feet. So this is a young boy that I met that had sort of very tall, was playing basketball, and sort of complained typically after playing a game that he had neck pain. And that if he wasn't very active, was not having much pain, but then the more active he was, the more pain he would have. So we saw him in clinic, and essentially what we were trying to look at, these are flexion extension films, so we're looking at him from the side. You obviously see his jaw in the base of his skull, and that as you sort of draw lines, which is the anterior part of the cervical spine, as he bends forward, you see that the C1, C2, so where that sort of central dot is where the spinal cord is, as he bends forward, you get this instability between C1 and C2. And that's really a question of ligaments that normally hold that, so that if the ligaments are taut and strong, then you do not get that aberrant mobilization. But now this child has resulted in either overextension or just, again, his underlying connective tissue disorder has led to this instability. And then sort of pushing the imaging, here's an MRI that sort of shows that on extension, there's room for the spinal cord, but as the child bends forward, the part of the arch of one is compressing his spinal cord. And therefore, if you look at the film back here, there's a divot. And again, so because of this instability, this child's at risk of paralyzing if he has an accident, or over time, he lose some of his function as the spinal cord is being pinched. So again, there is surgical management of it, and if therefore there is cord compression and that child is at risk of paralyzing, better to act earlier than later. And that's really is required surgical stabilization. Surgery is fairly straightforward. Granted, there's a lot of vital structures that are traveling, but the idea is that you essentially want to create a synthetic bony bridge between the first arch and the second arch, holding that into place so that that aberrant abnormality no longer is placing the spinal cord at risk. So just moving on to sort of scoliosis, and you know, the definition of scoliosis is really this lateral curvature of the spine that is sort of greater than 10 degrees. But if you really take time and look at the real deformity, there's much more than just pure lateral bend. And that it's really a rotational deformity that is in a three-dimensional. It's this helical change that happens over time. As the child grows, the internal mechanism that allows the stability of the spine is lost. And then because a bit like the Leaning Tower of Pisa, because it started leaning, gravity's making it lean even more and rotate even more. And with growth, you get this compounded effect that the deformities progress. So again, this is just, again, to highlight the issues that all these children have idiopathic scoliosis. They all have scoliosis. but their underlying diagnosis is very different. You have a 13-year-old who essentially just complains that she's a bit shifted and she has a bit of pain, compared to this boy that is wheelchair-bound, can no longer sit in his wheelchair because his spine is so deformed. And then you have a 9-day-old that has this sort of structural deformity. He has hemivertebrae, so he's born with innate aberrance in his structure of his vertebrae. And finally, the last one is that he has this severe deformity and that his bone is brittle and that he's led to have this progressive deformity. So when I teach about scoliosis, being able to identify the underlying diagnosis dictates the type of treatment for different patients. So there's really 5 broad categories of scoliosis. And if you look at the 4th one, is what I call this mesenchymal scoliosis, which is really the innate tissue or the connective tissues that, because of this hyperlaxity, this tissues and the ligaments that form either the bones or the proteins that form the bone or the ligaments, you have this inherent instability that leads to these deformities. And then having this classification allows you to better identify the associate pathologies. So just as a highlight for an example, the 7-year-old that presents with scoliosis, which is a bit unusual because normally scoliosis tends to present a bit later. And then when you examine them, they actually have this little hairy patch. And that, so you say, well, why is there a tuft of hair at that level? Well, it turns out that it's a clue that the spinal cord is abnormal at that level. So that there are hidden disasters lurking underneath the surface, that even though the children show up or young adults show up with scoliosis, there is a possible reason for these deformities. And as physicians, we need to sort of work and try to identify those. So this is a 14-year-old male that shows up that has the skewed foot. And it turns out that, not sure he had LDS, but anyhow, he had some connective tissue disorder for which, for the purpose of the presentation, I said, well, this child may have Loeys-Dietz. And the reality is, well, what are we looking for? And therefore, based on my clinical assessment that the child has scoliosis, I really have to exclude all the other hidden disasters. And how do we do that is through a history and physical. And essentially what one wants to work up is really looking at valvular disease, aortic aneurysms, arrhythmias. He may or may not have cervical instability because of having connective tissue disorders. We know that their spinal cord, there's a sac that sort of holds the spinal cord and the cerebral fluid. And that is made of essentially elastin, and as the pulsation occurs through the nervous system, the bone is dilated, and you get this dural ectasia that leads to significant problems and instability of the spine. So the idea is that when the child sort of shows up, even though they have scoliosis, as physicians, we're sort of looking for the zebras. We are looking or trying to rule out what's really at the source of this deformity. And the more we understand what's happening, and the more we understand what are the possible associated abnormalities with what's at surface, the less the patients are going to get into trouble. And that's why, again, so if you have a child that has connective tissue disorder that shows up with scoliosis, well, there's mandatory investigations. And for me, and this is where sort of, my earlier questions, I do send them for an echo of the heart. And then if we have a definite diagnosis, well, the issue is getting an MRI. I get an MRI for the spinal cord to look for dural ectasia, which is essentially an MRI from the base of the skull down to the pelvis. And again, through conversations with the galleys, now I include the head. And again, just to making sure that the issues that we're not missing and getting a flexion extension film. So that as you advocate for your own health, I think the issue of the more you understand what's at risk, the better you're prepared to actually be a good advocate as you show up in emergency and different issues. So then the issue is about, well, once you've made a diagnosis of scoliosis and a connective tissue disorder, what are the likelihood that curve will get worse? And again, based on history and physical and timing of surgery is really dependent on what's going to happen over time with scoliosis, with growth. So again, if you have a child that has a small deformity, as they grow, that deformity may get worse. And that we know that growth is sort of bimodal, so the kids grow a lot from the age of 0 to 5, and that's when you get a lot of changes. So if you have a deformity that's already present at the age of 1 or 2, I'm really worried that over time that deformity will really get worse. Compared to if it's showing up in a bit of a later age group, there's a second peak of growth, and that's where things again may change drastically. And that's when the monitoring of these deformities need to be a bit closer. And then there's a bunch of different x-rays that allows us to better pinpoint have they gone through their peak growth or they have not, and that we sort of do that all in clinic. So then if you look at the natural history of curve progression, so that we know that there is the amount of growth that's left is dependent, will influence the amount of risk of progression and also the curve severity. So if you have a small curve, yet you have a lot of growth, you're still at 22% chance that that curve will get worse. But if you're young and you already have a big curve, the likelihood is that you will progress and you will need some form of treatment. Compared to if you're much older and you have a small or medium curve, again, the risk of progression is really mitigated. So the basic principles in respect to sort of the overall management of scoliosis, typically a curve from 0 to 20, we tend to, don't worry about it, we will observe. In patients that have connective tissue disorder, we will observe for you much closer because the risk is that because of the connective tissue disorder, you're still at risk of that curve progressing. If you don't have connective tissue disorder, the likelihood of that curve to progress is very small. If you have a curve that's between 20 and 50, typically we brace, and when the curves are above 50, one embarks on surgery. The type of surgery, again, is really dictated with the problem at hand. So this young boy had severe deformities, had not been followed, and the curves were now reaching 120 degrees and 110 degrees, and that he was having difficulties ambulating, having difficulties to actually breathe. His bone quality was poor, and that as we approach these type of deformities, we really need this multidisciplinary team approach. And again, as you've seen, I think any patients that have connective tissue disorders, you do need to be followed by multiple specialists because there's a lot that is in the background that you need to make sure that you optimize before you decide to embark on any form of surgical management. The other thing I would tell you that connective tissue disorder, because of the building blocks, because of the tissues are not as rigid or solid, their healing potential tends to take a bit longer. And from an orthopedic point of view, we've seen that the complication rate are much higher in patients that have connective tissue disorder than patients that do not, and that it is not unusual to have to go back and do secondary surgeries because if the bone doesn't heal, eventually the metal breaks and then you have to go back and put more bone. And that sometimes what happens is that you fix one area and then segments either above or below wear out because again, they're not fit to be able to withstand the mechanics that one would expect should be able to maintain. So just maybe quickly in respect to club feet, and again, it's a bit unusual that, so this was a newborn that was born with hypotonia. So again, so the muscle tone was decreased, so the muscle strength was less. And again, we typically see this in patients that have connective tissue disorders. And that he had a little, even at that age, already had a bit of a kyphosis. And again, if your muscles are unable to remain upright, you end up being at risk of developing deformity. And then he had his feet that were actually fairly rigid. And therefore they had to embark on a conservative management and serial casting. So the treatment for sort of foot deformity is really non-operative. If you think about the forces that go through your feet, as soon as you start altering or embarking on surgical management for the feet, patients tend to have much more difficulties and so on. So the mainstay of treatment is really these conservative management, looking at cast, looking at multiple manipulation. So in conclusion, just sort of broad principle in respect to orthopedic management in the face of connective tissue disorders. So always check their C-spine and to a certain degree getting a flexion extension film. The frequency of which you'd recommend to have this depends on the age of the patient and the overall, like I was telling you, the overall laxity scale or the impression that they have a lot of instability or laxity or not. Second one is really, in respect to feet deformity, manual therapy, serial casting is really the mainstay. In respect to scoliosis, early screening, repetitive assessments, early bracing, and even early surgical management so that the deformity doesn't get out of proportion because then the forces to bring things back are putting much more strains on the balance of the spine. In respect to osteoarthritis, it's really trying to offload the painful joint, so using canes or aids is really the sort of the initial step. And then if you're embarking as the joints have destroyed, the issue with some of the joint replacements is that you replace the joints, but because the soft tissue around them are not solid enough, you need to have these semi-constrained hip replacements or knee replacements. Again, prevalence and avoidance of activities really decrease the forces across the joints and therefore decreasing injury. If you're thinking about, there's this motto in orthopedics that, life is motion, motion is life. One of the best exercises that I would recommend is really swimming. You're not putting a lot of your joints under load and that you're able to try to maintain muscle bulk with minimal constraints on the joint. Foot deformity is really custom shoe wear. And then for hypomobility or hypotonia, it's really physical therapy is the main issue. respect to recurrent fractures, which we're starting to see now, is really, we're not really sure if medical management that we, such as the permidronate and sort of bone-sparing remodeling therapies may or may not help. So this conclusion, treatment should really maintain or prevent pathology. So if you have an early mechanical deformity or limb deformity, trying to be much more proactive before letting things hang out. The challenge still remains that due to the poor tissue, reconstructive surgery is really demanding. Thank you very much.
Thanks so much, Jean, for that fantastic overview. We'll take a couple of questions. We'll have more during the workshops. Yeah.
Quick question. So, Dr. Ouellet, my wife mentioned that swimming is not good for the hair, so that would be...
For the hair? Oh,
that sort of thing.
that's why we need multi-specialists.
So a lot of our patients go through surgeries, multiple surgeries. So can you just talk to, because of the cervical instability, either intubation, and what should the surgeon or anesthesiologist be looking out for in that whole prep and surgical?
So the issue of cervical instability is real in these patients, and so typically getting a flexion extension film, the normal displacement that is acceptable is less than 4 millimeter displacement. Give you an example, a child that has Down syndrome, again, that has this hyperlaxity because of some connective tissue disorder, we do not stabilize that spine until we actually get 9 millimeters. So there is a play. So it doesn't mean that you have instability, that you need a spinal fusion. It's really the amount of displacement, and really is the displacement causing an encroachment on the spinal cord. And that is really getting the MRI, which is a dynamic MRI. If you have evidence that your spinal cord is being pinched, and that this will tell you you do need surgical stabilization before proceeding with elective surgery.
And when we talk about going in for a cardiac surgery or something else, and just what should the anesthesiologist or the surgeons and the other disciplines be looking at when they're doing either intubation or anything else?
Well, so again, so if they document some form of instability, you are able to intubate somebody that has cervical instability. They need to have additional precautions. So essentially, somebody needs to stabilize the neck as they're intubating. There's different techniques. So you could use fiber optic intubations, and there's a multitude of things. You know, the issues of being aware of the possible risk of instability. Again, if you are documented that you do have instability, again, having a medical alert on your bracelet so that you know, there is standard ways of intubating that you do not mobilize the neck, or you're not putting the neck at risk.
Hi. I'm scheduled right now for double knee surgery, double knee replacement, sorry, and getting ready to replace my ankle too. So I just was diagnosed last week with Loeys-Dietz. So I was just kind of curious as to how much that changes.
Yeah, so the issue is, again, a bit what I was alluding to. Part of the reason, or most likely the reason why you've developed arthritic changes to a certain degree, is this hyperlaxity around those joints. You conveying that to your orthopedic surgeons that are planning probably will not change the surgical management based on his physical exam, but he may want to spend a bit more time to really appreciate the amount of possible laxity that you have. In the knee joint, you know, we have ligaments. So we have the anterior and posterior cruciate ligaments that provide some stability, as well as your lateral collaterals. So as you embark on a knee replacement, you have to assess how floppy, yeah, and therefore there are different prostheses that actually constrain. So they're called semi-constrained knees that are well established, has been used for different reasons. So some patients actually have had an injury, have torn their cruciates, therefore they're incompetent. So you know that for those patients, you can't rely on those structures. So therefore, the prosthesis has to be modified for that typical patient. So again, you being able to convey that to your surgeon will help him to sort of maybe take a bit more time to ascertain the instability around the joints, and that there are ways to compensate for that.